So good morning, good afternoon to everyone. Thank you for joining us. This is our third Public Health Leadership Seminar Series talk, and the title is Use of Disease Data to Guide Public Health Actions. So we're going to be looking a lot about data, surveillance systems, and how do we use this data to help us make better public health guidance and policies and actions. So my name is Dr. Esther Tan. I'm in charge of the public health section of DHMOSH. And today we have the privilege of hosting Leslie Ann Helmus from the CDC. So before I introduce her, I just want to tell you that this leadership series is really targeted mainly at our healthcare professionals, as well as anybody else who's working in public health. We have three purposes. One is to empower you with the foundational tools needed to improve public health practice in your duty station. Two is to prepare you to respond to a range of public health emergencies in your duty station. And three is to help you develop leadership skills and management skills within the public health and medical community. So if you have not yet checked out our website, we'll put that in the link, and you can look at the various public health programs that we have. If you're also interested to be on the mailing list for future webinars, we will put the link on so that you can sign up for this particular series. We are going to try our best to mute everybody online who's not speaking. So if you can, please mute yourselves as well. If you have any questions during the webinar, feel free to put it on the chat box, and we will save the last 10 minutes to go over any questions. Please note also that this webinar is being recorded, and a link of the recording will be available to all of you after the talk. So with this, I am very happy to introduce to you Leslie Ann Helmus. Leslie Ann is currently the Associate Director for Surveillance at the CDC's Division of Health Informatics and Surveillance. In this capacity, she coordinates disease surveillance activities for the division. She works on surveillance and informatics initiatives and provides advice on surveillance and informatics strategies for other programs at the CDC, as well as the US federal, state, and local agencies. Prior to this, she served as the program manager for the National Notifiable Disease Surveillance System at the CDC. And before that, she served at the state level, working on public health surveillance program for the US. So we're really super happy to have her on board. Of course, you can see from her experience that a lot of it is based in the US, but I've asked that she talk about the experience in the US with the understanding that we want to see how we can learn from centers of excellence and see how we can apply it to different settings that you are in, that the UN is working in. So just to say that a lot of the experiences shared would be illustrative in nature, but it's also part of the training and learning. So without further ado, I'm going to hand over to Leslie Ann. Leslie Ann, over to you. Thank you so much.
And can you see the screen at this point?
Yes, we can.
Okay, great. So I'm pleased to be speaking with you today. As Esther said, my name is Leslie Ann Helmus. I work for the US Centers for Disease Control and Prevention. My focus is on public health surveillance activities and the information systems that collect and manage and use the data. My formal training is in epidemiology and public health informatics. Before coming to the CDC, I did work in a number of state public health agencies at the state level. So I plan to talk about public health surveillance strategies and considerations for setting up a surveillance system. I'll dig down a bit into case-based surveillance and syndromic surveillance, and then I'll touch on some of the emerging technology opportunities that may change how we access and manage the data. As Esther said, it's important to recognize that the same strategies and approaches will not work everywhere, but the underlying principles are the same. Some of the things I'll mention are new opportunities that are just emerging. I hope they lead you to think about innovative approaches to obtaining and using data. You'll find many definitions of surveillance in the literature, but they all address the key features. The first is that surveillance is ongoing data collection. It gives us information over time so that we can compare what is happening now with what happened in the past. And potentially, it can allow us to forecast what we might expect in the future. It's systematic, and the data is collected in the same way in all the locations involved and over time. This makes the data comparable. This consistency is achieved through surveillance protocols that specify what's collected and how it's collected, specify the data sources, and how it's aggregated for analysis. Case definitions indicate which events should be counted, and data standards indicate which data elements to include and what code sets should be used to represent the data. The purpose in collecting surveillance data is to put it to use. So all the surveillance definitions emphasize analysis and interpretation of the data to put it in context and to draw out meaning. And finally, they emphasize the need to present the data to those who will act on it. The data should be made available in readily accessible and easily understood formats. Having good data is essential to effective public health. The wheel on the right shows the role of data, including surveillance data, in supporting the core public health functions. The orange monitor health segment is where surveillance data and other data is collected. And the red diagnose and investigate segment is where the epidemiologic investigation occurs. The data they produce are the foundations for all the actions that follow. And note again, the data is needed in the dark blue evaluate segment at the top, where it helps us to determine whether public health strategies are effective. How we intend to use the data should guide our choice of strategies. When we're planning surveillance, it's important to define and understand the intended uses. This helps us ensure that we select strategies that are able to answer the questions, and it helps ensure that we don't collect data that's unneeded or that unnecessarily risks patient privacy. One thing to think about as we talk through these uses is how the same data might be used differently at the local, regional, national, and international levels. First, we use data to detect illness in the community and to determine if public health action is needed. For some conditions, like measles or polio, one case requires action to protect the community. For other conditions, we're looking for more cases than is usual in the situation, like an outbreak of foodborne disease or a cluster of cases in a specific setting, like for high blood levels. We also watch for conditions to emerge in a new area. For example, when SARS jumped from one continent to another. We also use surveillance to characterize disease. We need to understand how much disease occurs, if there are increases or seasonal trends, whether it's concentrated in some geographic areas, or if population groups are at higher risk. With this information, we can change disease screening recommendations or make sure that physicians know when a drug-resistant organism emerges in the community. We also use surveillance to monitor healthcare utilization. For example, to identify populations that are not fully immunized or who are diagnosed at a late stage of disease. Surveillance data allows us to monitor disease, to understand how it's spread, the course of illness, and what puts an individual at risk. Often, studies that identify changes in etiology or risk factors occur at the national level and results in new guidance, changes in disease control strategies, or improved lab tests. We also monitor cases, like with directly observed therapy for tuberculosis, to make sure that patients adhere to treatment. Finally, the data helps public health respond. It indicates where and when public health action is needed. At the local level, this might mean targeting mosquito spraying or changing restaurant food handling requirements to prevent foodborne disease. At the national level, it allows evaluation of prevention and control strategies or redirection of funding to highly impacted areas. When designing a surveillance system, these are some of the things to think through. First, be clear about the purpose and objectives. Understand what questions you want to answer, what kinds of actions will be taken, and who will use the data. Second, identify the strategies you'll use. Consider legal authority to collect the data, where the data will come from, how you'll get it, and where it will be stored. You'll want to ensure that you have clearly defined criteria, such as case definitions, and that you identify what data elements to include and what value sets to use. Third, consider how you'll analyze and disseminate the information. Thinking this through may cause you to go back and refine some of your earlier thinking about what data is needed and where you should get it from. Finally, after you've implemented the systems and used it for a while, remember to evaluate whether it's providing meaningful information, if the data needs have changed, and whether it's efficient and easy to use. This may lead you to go back and modify your original plans and change how you're doing surveillance. The strategy you select should be based on your surveillance objectives and also on the opportunities that are available to you. Case reporting is a foundational approach to public health surveillance. It generally uses clinical, laboratory, and epidemiologic data to identify those with disease, and it guides disease control. Laboratory reporting is an efficient way to monitor for disease events that are easily detectable with a test. When negative results are captured as well as positive, it can be used to monitor trends in positivity. Disease registries track people over time and provide valuable information on the course of disease, like with cancer, or capture multiple events over time, like the vaccinations. Vital registration, birth and death data, isn't always thought of as surveillance, but it allows us to monitor which conditions have fatal outcomes, identify birth defects and other conditions identified at birth, and it provides valuable indicators like life expectancy and low birth rate. Vector surveillance, for example, monitoring for specific types of mosquitoes, has become increasingly important with climate change as mosquito vectors move to new areas. Risk factor and disease prevalence surveys provide information on things like seatbelt use and tobacco use and diet. They also provide information on conditions that are not usually reportable to public health, but are of concern, like high blood pressure or diabetes. Environmental monitoring helps us identify hazards in the air or the water so they can be controlled before they cause serious illness. Genomic surveillance provides insights into the changes in virulence, into emerging drug resistance, and into populations at risk for severe complications from disease. Additional data sources are being incorporated into public health surveillance. Many of these are collected for other purposes. For example, health insurance claim data has been used for insights into chronic disease levels. Social media data has been used to monitor when people are messaging or concerned about flu or other diseases. And during COVID, mobility data measured the distances cell phones traveled, and they produced an indicator of whether people were adhering to stay-at-home guidance. In the next slides, I'm going to dive into more detail on case-based disease surveillance and then on syndromic surveillance. Case-based surveillance is intended to identify all cases of a condition of interest so that public health can take action to see that the person receives appropriate treatment and to control the spread of disease. Generally, case definitions are very specific about when an illness should be counted as a case. Criteria include things like signs and symptoms, lab tests, exposure to a known case, and sometimes the cause of death. Some conditions are only reportable if they occur in a population of interest for the condition. For example, there are some conditions that are only of interest if they occur in a child. Or they may be of interest only if they only occur in a specific setting, like if the exposure was job-related. Efficiency and data quality may be improved when we automate processes. When computer algorithms can be used for case detection, for example, finding potential cases in an electronic health record, or an algorithm can be used for case classification, it is able to make sure that a case meets the definition. For case-based surveillance, the information that's collected generally includes things like clinical information used to confirm and describe the disease, demographic information about the patient, healthcare information about services received and severity of disease, lab tests and findings that confirm the illness, medications used to prevent and to treat the condition, whether the person was vaccinated against the disease, and risk factors that might explain how or why they acquired the disease. Historically, paper-based case report forms told the physician what information to submit to public health and guided the public health staff in their case investigation. But these paper-based approaches are being replaced with more electronic processes. In some cases, trigger codes are being used to identify reportable events in an electronic health record and to send an electronic case report to public health. Then automated decision support at the health department can match a new report coming in to other information that's already been acquired on a patient. And finally, algorithms may determine if the case meets the case definition. Effective automation can free staff for the activities where their thought and their judgment are needed. This graphic illustrates a common flow for information for case-based disease surveillance. Often hospitals, healthcare providers, and laboratories with information on a reportable disease send the information to the local public health agency. Public health staff then collect additional information as part of the disease surveillance and collect additional information as part of the disease investigation, and then they implement disease control activities. Passive surveillance relies on healthcare to identify reportable events and submit the disease reports to public health. In contrast, in active surveillance, the public health staff engage the facilities to identify cases and to collect the needed information. This active approach is much more research and resource intensive for public health, but it can provide more complete information, and it's sometimes used to audit the completeness of passive reporting. Case information is generally forwarded from the local level up to the national level to provide a national picture. At this level, data is used to understand disease etiology, to monitor prevention and control strategies, and to allocate funding. When the condition is of international concern, information is forwarded to the World Health Organization. Patient name and other identifiers are needed at the local health department level to merge data from multiple sources and to follow up with the patient. But often, the identifiers are removed when the data is sent to regional or national offices to protect patient privacy. We also want to mention two variations that are sometimes used. In aggregate reporting, only aggregate counts are sent from healthcare provider to public health, or from the local health department to the regional or national level. This can be useful for showing general volume of visits and counts for disease, but it doesn't allow for deduplication of reports, and it's difficult to understand the epidemiology of the disease. Another strategy is sentinel surveillance. In this approach, a few highly capable facilities that are likely to see cases are identified to conduct surveillance. While this does not provide information on every case, it can provide useful indicators of trends and allow for the collection of detailed information at a reasonable cost. Case-based surveillance is generally analyzed using the traditional epi curve. This allows us to look at data over time to understand background disease levels and to monitor trends. This graph shows the daily trends in COVID cases in the US. The red line smooths the daily variation to show the overall trend. In the center of the graph, you'll see the large peak that occurred in the US last winter. Of note is the steep drop that occurred in January when vaccinations began. Maps are a useful way to show where disease is occurring. Presenting data as rates per 100,000 population, as on this map, make it easier to compare areas. This data is displayed on a data dashboard on a web page, making it readily available to people who need it and allowing them to interact with it. For example, you can see the white pop-up box that provides more detailed information on a state. It's also important to look at groups within the population, to identify subgroups at higher risk, and to monitor changes in groups over time. This may help target prevention strategies and educational messages. Again, using an interactive display of data on a web dashboard allows users to explore the data, but it can also be used to limit their access to views to protect patient privacy. Now I want to talk about syndromic surveillance. This is a newer approach to surveillance. Rather than defining conditions of interest ahead of time, it collects minimal data on health visits, usually within 24 hours of the visit. We've focused on emergency department visits. As public health questions arise, a syndrome can be defined as a statistical algorithm, and then other tests can be used to compare current levels to past levels, and then the information can be used to guide action. This is proven to be a flexible and timely source of information, especially when other surveillance doesn't exist. It may be used by itself, but often it's integrated with other data sources to provide a more complete picture. Syndromic surveillance has been applied to a wide variety of situations. It's been helpful for surveillance of emerging infectious diseases and identification of outbreaks. It's used every year to identify when seasonal influenza activity begins and ends. And as COVID-19 first emerged, we were able to track the spread across the country by monitoring increases in people seeking emergency care for COVID-like symptoms. It provides unique information for monitoring chronic diseases and their complications, including diabetes and asthma and mental health conditions. It's proven valuable for understanding injuries without setting up another surveillance system. When an opioid overdose epidemic emerged across the US, local health departments could identify increases in overdoses in their community within hours. This allowed them to issue warnings that more potent drugs were circulating and to ensure that patients were linked to care. It also helped to show law enforcement and politicians and doctors that the problem affected all parts of the population. It's proven helpful for monitoring health effects around mass gatherings that bring together a large number of people for a few days, especially for events like sporting tournaments and political gatherings. It's been used to monitor health effects from environmental conditions, like the smoke from wildfires and health effects from severe hot and severe cold weather. It's provided information to healthcare to help them prepare for disaster situations. It's shown that immediately following hurricanes and floods, people seek care for basic urgent medical needs like medications and dialysis. That later they seek care for mental health issues, and that when recovery and rebuilding begins, they seek care for injuries. This is an example of a syndrome definition for opioid overdose. You can see that it's long and has lots of clauses and phrases in it. It draws on keywords from the patient chief complaint, and it also includes ICD codes from the physician's diagnosis. Syndromes may also exclude explicit terms to exclude events. For example, the syndrome for influenza uses the words influenza and flu, but it explicitly excludes visits that were for an influenza vaccination. This graph shows an analysis that was based on the syndrome for suspected opioid overdoses that was on the previous slide. While increases in the rate of opioid overdoses were seen in all regions, the increase in the Southeast in the last quarter stands out. This graph shows the sudden increase in emergency department visits for e-cigarette or vaping-associated lung injury, which is referred to as EVALI. This was first identified during the summer of 2019. When the syndrome was defined, once that syndrome script was written, it was applied to the historic data on visits to provide a baseline for comparison. This was important in showing that something new was occurring and in pointing out the much greater impact in males, shown in the blue line, than in females in the green line. The syndromic data can be analyzed by age groups to identify those at highest risk and to monitor for changes. This graph shows the percent of emergency department visits for COVID-19 by age group. And again, you can see the impact of the COVID vaccine on the older age groups in the dashed and solid purple lines at the top of the left peak. And then when they began to be vaccinated in early 2021, these rates dropped dramatically, and those groups then were buried further into the rate lines here. This data can also provide insights into healthcare utilization. The light blue line shows emergency department visits by week in 2019. The dark blue line shows visits in early 2020. You can see where emergency department visits, you can see where emergency department visits dropped dramatically and suddenly the beginning of the COVID epidemic. They dropped by about 42%, and then they slowly rebounded. It's likely that injuries and strains were seen in other settings, and telemedicine might have been used to address some health needs. But there was a real concern over the decrease in visits for chest pain and myocardial infarction. This suggested that people were delaying care for potentially serious conditions. Public health put out messages urging people not to delay care for potentially life-threatening conditions because of concerns over COVID. For those of you who are interested in learning more about syndromic surveillance, this publication provides an overview of a wide variety of applications. I want to touch on some surveillance challenges and then point to some technology approaches that offer promise to address them. Many public health agencies have multiple uncoordinated surveillance systems. We've identified over 120 in my organization. Because they were developed independently, they don't share data standards or approaches. This has resulted in siloed data systems with redundant technology and duplication of effort, and data that's difficult to integrate. It also presents a burden to data submitters who need to send data in different formats and through different routes. Despite well-tested technical solutions, public health has often been slow to adopt technology and often doesn't have enough people with the needed skill sets. Finally, data access and sharing policies may need to be modernized to take advantage of the expanding information and new technologies that are available. Public health and surveillance have experienced major changes, but in the increasingly digital world we're facing, we need to accelerate that change. The public and government officials expect public health to have sound information almost instantaneously, to share the evidence so others can see it, and to act on it rapidly. As we saw in COVID-19, if we weren't able to produce the data quickly, others would produce data. And while sometimes it was sound and reliable, sometimes it fueled misunderstanding. Data is being captured and transmitted and shared in new ways. It's becoming a commodity that may complement or replace our traditional public health data sources. We need to rethink how we acquire data and what we need to collect, how we share the data that's uniquely a product of public health. We need to be able to use the new high-volume data sources, learn how to link data for greater insights while still protecting privacy, and incorporate technology to handle the data, and also cultivate the skills in our staff to make this possible. Some of the new technologies make it easier to access and exchange data. Some of these technologies are basic and widely available, like the use of mobile devices. They've been used to collect information from those involved in a foodborne outbreak or to send health reminders to pregnant persons, but they may also help monitor compliance with stay-at-home mandates. Some innovations or some standards, like vocabulary and data standards, are well established, but they require a commitment to adoption. Other approaches, like FHIR as a content standard, are still evolving but offer promise. And innovative new strategies are emerging, like privacy-preserving record linkage, where a third party receives the identifiers and creates linkages based on the identifiers, but they never see content. And that enables data consumers to use the linked records without ever accessing the patient identifiers. New technology approaches are going to be needed to manage the volume and the complexity of the data. Cloud storage and data lakes are addressing the storage and access issues. New, powerful open source analytic tools are making analysis of these large, complex data sets more possible and more efficient. And public health is developing the skills to automate processing of non-structured data, like machine learning, natural language processing, and artificial intelligence. With data integration platforms and powerful visualization tools, we're able to more quickly integrate the data from multiple sources, to get intelligence from the data, and to present the findings intuitively, and to use the information to identify emerging problems. But to take advantage of these opportunities, and even to understand what they offer, we do need to continue to build and enhance the public health workforce, and to share what we learn among partners and others doing the same work so that we all benefit from the knowledge. And finally, these are some reminders as we think about modernizing public health's approach to data. We need to build a sound technology foundation, keep improving how we acquire and use data, cultivated the needed skills in our workforce, and build strong partnerships to address the challenges and manage the change.